So today I'm going to be speaking about the nutritional needs of people with cystic fibrosis. And I think that the prompt from the community was talking about like calorie and protein needs. And so I took that and then built this presentation on it. So I hope that we can have a big conversation and I answer some questions. And of course, like I know this group is super interactive, so feel free to interrupt, and there's definitely time at the end too. So today's outline looks a little like this. I'm gonna talk about the nutritional goals of people with cystic fibrosis. I'm gonna talk about the metrics that we look at to evaluate folks' nutritional status. I'll talk about the specific nutritional needs for people with cystic fibrosis, interventions that we use to optimize nutritional status. And then, like I said, there will be time for questions and answers. So let's get started. So what are the goals when we talk about having a nutritional, optimized nutrition for people with CF? Well, nutritional status is associated with improved survival and quality of life in the cystic fibrosis population. So we seek to improve and maintain a healthy nutritional status as like the primary goal. As dietitians, we work across patients' lifespan to promote optimal growth, so from childhood onward, and optimal development, to prevent and treat malnutrition, to prevent and treat nutrient deficiencies, and to preserve lean body mass and promote a healthy body weight. This presentation is a little tricky because, as you're all aware, every individual with or without cystic fibrosis has individualized nutritional needs. And then also, since the introduction of the modulators like Trikafta, Yelencich, the nutritional needs of the population has changed quite a lot. There's a wide variety of what people with CF are trying to do with their nutrition. So I tried to make this presentation as applicable to the widest variety of people as possible. And I'm going to speak to different nutrition statuses. So I'll speak to undernourished population, well-nourished population, and occasionally over-nourished population as well. So like I said, interestingly, the landscape has really changed, and we've seen that the number of undernourished patients with cystic fibrosis has gone down over the last 5 to 7 years, and the population with an overweight or obesity has increased. So just a changing landscape. Doesn't mean that there isn't nutritional needs across the population though. So what are the metrics we look at to evaluate nutritional status? The first that I want to talk about is body mass index, which you've probably all heard of before, BMI. So I put the references over here. Undernourished in the CF population, we consider a BMI of 19 or less, which is a little higher than the general population. And then overnourished, we look at a BMI of greater than 25 as overweight and a BMI of 30 as obese. There is an association between undernutrition and clinical outcomes in cystic fibrosis, and things like pulmonary function, quality of life, mortality risk. So if you have a lower BMI, like in the undernourished category, you're at a higher risk for poorer lung function, poorer quality of life, and higher risk for mortality. And then vice versa, a higher BMI is associated with better lung function in this population. So I'm sure all of you have been hearing about your lung function your whole lives, very motivated to get the best lung function, right? So in the research, we've seen that the target BMI for a patient with cystic fibrosis is higher than just avoiding malnutrition. So we don't only want people to have a BMI higher than 19. We actually see that folks with a BMI between 22 and 23 have the most optimal lung function. So for women, that's 22, and for men, that's 23. Patients with a lower BMI are 6 times more likely to have severe lung disease, which is evaluated as an FEV1 or forced expiratory volume of 40% or less predicted compared to patients with a normal BMI. So there are clinical associations between BMI and like your clinical status. And I like to talk about, one reason why a higher BMI may be protective as far as lung function goes is that people with a higher weight also have a higher muscle mass. And as we know, you need healthy muscles to breathe and support your lungs and things like that. And so that's one of the reasons why that higher BMI may be protective. Now, BMI isn't a perfect metric. I have personally a lot of issues with BMI. BMI is only weight to height. So it doesn't consider body composition, which we'll talk about on the next slide. It doesn't consider weight history or what kind of your maybe status quo weight has been over your lifetime. It is, the BMI was established in Caucasian men. So it doesn't take race or ethnicity into the metric. And the data that we use for the FEV1 here was from pre-modulator era. So there's we got to take all of this with a grain of salt. And in my practice, I take BMI kind of liberally. So body composition. This is a more accurate assessment of what your body's actually made of. So things like muscle, fat, bones, organs, blood. And when we assess body composition, we want to look at fat mass and fat-free mass rather than only weight. And fat-free mass is constitutes skeletal muscle, bone, connective tissue, organs, and blood. And then the rest is your fat mass. And so it has been shown that there's a stronger association between fat-free mass, so things like muscle. Well, let's just think about muscle when we think about fat-free mass. So there's a stronger association between muscle and respiratory outcomes compared to BMI and respiratory outcomes. So it's kind of more accurate. It has also been shown that patients with low fat-free mass and a normal BMI, so maybe the BMI, say, is that optimal 22 for a woman, right? But they have not so much muscle mass. That's associated with a lower FEV1 percentage than patients who are overweight or obese. So we're kind of breaking down the problems with the BMI when we look at body composition more specifically. So how do you measure it? Body mass impedance, which many clinics have, to my understanding. I think you hold on to a thing and it kind of sends a charge through your body, or a DEXA scan, which is quite accurate and, in the guidelines to get done pretty regularly for folks with CF. So how do we promote fat-free mass? Eating enough, both overall calories and protein, and then using your muscles. So exercise. And this is going to be, I think last year I beat a dead horse about the bowel regimen. This year I'm going to beat a dead horse about exercise. Okay, and then obviously another way that we assess nutritional status, which is my main role, is assessing folks' diet. So when we assess for diet, we look at whether a patient is getting enough nutrition, so overall energy intake. We assess for protein intake. Are patients getting enough protein? And then, and these are kind of I actually put these in order of priority. So if you're not getting enough calories overall, you're going to be undernourished. If you're not getting enough protein, then your nutritional status is compromised, right? Then we go to diet variety or diet quality. So are you eating, how liberal is your diet? What are the barriers to eating a more liberalized diet? And then as far as quality goes, that might be whether you're eating, super processed food, fresh foods. And then another role or another assessment that comes into play in nutrition is psychosocial and socioeconomic factors. So whether someone has the financial resources to eat a wide variety, access to variety or enough food, education level, both as far as education around nutrition and general education go, people's self-efficacy and motivation. So do they care about their nutrition? social support, whether folks have like help and support to prioritize nutrition, mental health and emotional states, those things play a big role in kind of how we're managing our nutrition. Physical health, so clinical status may play a role also in, if you're not feeling well, maybe you don't have the capacity to cook all the time. And then lifestyle, so things like, are you working full time? Are you taking care of a family? All of these psychosocial and socioeconomic factors also play a role in folks' nutritional status. So it's something that I take pretty seriously as far as evaluating the big picture. It's not just about telling people, this is exactly how much you need to eat and do it this way, because that's not really realistic in the real world. So there are other factors that we look at too for nutritional status. I'm sure you're familiar. We do nutrition-related labs every year. We do screening for diabetes every year. We talk about GI a lot, and then also talk about physical activity, right? And I'll get into some of these briefly further. So this part, I think, is getting to the core of what you folks wanted to hear about, which is how do we assess the nutritional needs of people with CF? And I split this into two categories. There's the underweight, undernourished, hypermetabolic, or the CF patient who needs a lot of calories, a lot of energy because a whole lot of reasons, which I'll get into. And then I have other slides on the kind of normal or overweight CF patients. So for this population, the hypermetabolic, malnourished, or underweight patient, I wanted to talk about why folks might fall into this category. So as we know, people with CF have more digestion and absorption problems, things like pancreatic insufficiency that can lead to underweight or hypermetabolism. Infections, frequent pulmonary exacerbations, your body's working really hard to fight illness, that increases your energy needs. Increased work of breathing. So when you're breathing really hard, I heard one of our attendings once tell a patient that she was basically running a marathon every day. Like that's how much work her body was putting in just to breathe. Activity level. So maybe someone is super, super active. That will increase the resting metabolic rate. And then also different medications come into play as far as affecting the metabolism. So how do we estimate the needs, the nutritional needs for folks in this category? The nutritional needs of a patient who is underweight or hypermetabolic can be up to 200% of the general population. So just the baseline nutritional needs. And so we see folks needing like 3,000 to 4,000 calories just to maintain their weight. And so the general rule of thumbs that I use in my practice that are research-based is 30 to 35 calories per kilogram to maintain weight. A kilogram is 2.5. You divide a pound by 2.5. So if you weigh 100 pounds, divide it by 2.5, and that's your kilograms. So 30 to 35 for weight maintenance, and then 45 to 60 calories or more to gain weight when you're in this hypermetabolic state. So very high calorie, right? And I'm sure you folks are familiar with the historic diet, just one second, of like the high calorie, high protein diet, right? And this, or high calorie, high fat. And this is because fat is the most concentrated calorie. You get 9 calories per gram of fat. And so you're kind of maximizing how much calories you get. Even on Trikafta, we have patients who are still underweight with a hypermetabolism. And obviously there are patients who also don't qualify for the modulators. And so if a patient is on Trikafta and their BMI is still low or they've been losing weight, then these numbers are still applicable. And then, yeah, like I said, if they're not modulator eligible, they may be in this category as well. After transplant, most often I see folks are after the acute healing, right? Not as hypermetabolic. So their metabolism is a lot more similar to the general population. Not everybody. And of course, after transplant, your clinical picture can change as well. So, if someone is having a tough time after transplant, they can go right back into the hypermetabolism. And then also, like in the acute stage, having CF still makes the baseline nutritional needs higher after transplant. So then the needs that you have on top of it are even more than that. But that's like 3 to 6 months or so. I mean, assuming everything goes smoothly after transplant. So protein needs vary for folks with CF based on your pancreatic sufficiency. So pancreatic insufficient patients require more protein per kilogram of body weight, because even if you're taking enzymes perfectly, the absorption is still not perfect. There's still abnormalities in digestion and absorption. And so we account for losses through the GI tract and estimate that folks who are pancreatic insufficient need 1.5 to 2 grams of protein per kilogram of weight. Folks who are pancreatic sufficient, we look at 1 to 1.5 grams per kilogram. And in the general population, historically, the recommendation was 0.8 to 1 gram per kilogram. That has slightly shifted to the 1 to like 1.2 grams per kilogram. So folks with CF who are hypermetabolic, even if you're pancreatic sufficient, likely need more protein. So that hopefully kind of like puts things on the spectrum of where people fall in the protein range. Okay, so what do we do? What are the interventions, which you kind of started touching on? We recommend the high calorie, high fat diet for this population. Some of the tips and tricks in this diet regimen are small, frequent meals and snacks. Sure, you've all heard that before. Including a protein food at all meals and snacks to optimize protein intake. We want as liberal a diet as possible. So this isn't the time where I'm going to be nitpicking about the quality of food that people are eating. We want as few restrictions as possible. And maybe someone has restrictions for other reasons. Maybe their GI system is unhappy. Maybe they had pancreatitis, So we want to eat as liberally as possible within each individual's specific needs. Then things like milkshakes, smoothies, heavy cream, those are my go-tos. And also high calorie condiments and toppings. So this is where the fat comes in. This is like topping your sandwich with as much mayonnaise as you can handle, adding avocado, sour cream. I tell people to put extra olive oil in their soups after they're done cooking, butter. These type of things are very calorie dense and don't add a lot of volume. Then other supplements, we went through some of the protein shakes. Then there's kind of like more medical grade supplements. So things like Beneprotein, Prostat, Benecalorie. Those are like, I think we call them modulators in the hospital, but you just add into different foods. I don't find people love these things very much, but just my experience. Other options to get higher calorie, MCT oil, medium chain triglycerides. It's like liquid. It's a liquid, and it is absorbed differently than regular fat. And so for folks with CF, MCT oil can be an added ingredient that is absorbed more efficiently and can help your body get more calories.
We have a question from the virtual retreat. What do you think about protein powder supplements?
Oh yeah, big fan. Protein powders are great. There's a lot of them out there. When I work with my patients, I usually encourage people to avoid creatine. Creatine is in protein powders for folks who are like trying to bulk up. And there is a lot of research going on about creatine, even specific to CF, but creatine is hard on kidneys. And so I'm pretty cautious about encouraging that supplement in a population that already is taking medicine that might be hard on the kidneys, particularly after transplant. It's a hard no. Pre-transplant, I'm kind of like, it's a little risky. So an individual basis. However, most protein powders don't have creatine in it.
We have a question from Kelly, who's online. I used to have a BMI of 16. Finally, my BMI increased and balanced to 18 for the last 2 years and steady. But oddly, my HDL and LDL spiked. How can someone needing a high calorie intake deal with a high HDL and LDL?
Yeah, it's a good question. It's a question that gets to a bigger question for folks with CF, which is with the modulators and longer lifespans, how do we manage the chronic diseases of aging? And so what we worry about with high cholesterol is heart health, right? Unfortunately, in the population, didn't really have to worry about heart health historically, right? And so we don't have a great answer to your question. And I think that because of what I was talking about up top of the risks of being underweight and being associated, especially with things like worse lung function, higher mortality, my practice and our team would say that maintaining a higher weight is a higher priority than having perfect lipid panel. There are medicines that can help with, we call it dyslipidemia, or having not a perfect lipid panel, cholesterol issues, things like Crestor or other medicines. I am not a doctor, so I don't know what the preferred medicine in CF population is for things like that. And I'm sure that there's a lot of studies going on to figure that out. But if you were my patient, I would maybe talk about unsaturated fats, like having more of the fat come from plants. So instead of maybe eating a diet high in butter, switching to things like olive oil, that could help the lipid panel. And then also things that drive high cholesterol are also added sugar. And so if your diet was also high in things like soda and sweets and things like that, I'm not saying there's no room for those foods, but talking about alternatives that might be easier on the body probably would be where I would start. So interesting question though. And yeah, I hope that I like to think about it of nutritional priorities, and this is a reason why. Okay, so more interventions. If you fall into the hypermetabolic category or malnourished, we do have appetite stimulants. So if appetite is one of the major barriers, things like Remeron or mirtazapine, that's the same medicine, Marinol can help promote appetite. And then we do use tube feeding or enteral nutrition. The goal for a tube feeding regimen is for it to be supplemental. And so we hope that folks will run their formula overnight to help get a boost of extra calories that you just can't get in the 16 hours you're awake or whatever, and then eating normally during the day. So that's the goal of the tube feeding. Then we want to make sure that folks are taking their enzymes correctly. If you're not taking your enzymes correctly, then your body probably isn't able to use the nutrition you're giving it as optimally. Evaluating your blood sugar control and optimizing it if you have diabetes. So there's the OGTT again, getting that done if you don't have diabetes, and then trying to get as tight of control as you can if you do. I'll talk more about the diabetes in future slides. And then physical activity, so weight-bearing exercises. Folks who are able to exercise and strength train with CF do tend to have a higher body weight because they've got muscle on them. Okay, then let's get into nutritional needs for well-nourished people with CF. So again, I'm going to talk about weight maintenance. It's the same, so 30 to 35 calories per kilogram. And then if folks are trying to lose weight, I'll estimate around 20 to 25 calories per kilogram. Again, the best way to do this is to evaluate what you're already eating and then talk about how to reduce from there if weight loss is what the goal is. But like I said, these metrics work pretty well. Protein needs are the same. So 1.5 to 2 grams per kilogram for folks with pancreatic insufficiency, and then 1 to 1.5 grams per kilogram for people who are pancreatic sufficient. And then So the fat intake, getting back to kind of the distribution, right? In the general population, the recommendation for percentage of fat of your overall calories is 20 to 35%. And so that's what we are targeting for folks who fall into this well-nourished or over-nourished category. So what are the interventions for this population? So in this population, I kind of approach it like the general population. So focusing on a heart-healthy diet pattern, which these other three fall into heart-healthy diets. So you may have heard of the Mediterranean diet, the DASH diet, or the MyPlate diet. So Mediterranean diet focuses on a lot of fruits and vegetables, a lot of plant-based protein and fat, with a little bit of animal protein and added sugar. So that's kind of the dietary pattern of that. And the other two are very similar. So MyPlate, I have a picture of a plate here. This helps you kind of like conceptualize the proportions of food, right? So half of the plate is a non-starchy vegetable. A quarter is a carbohydrate food, so rice, potatoes, tortillas, whatever it may be. And then the other quarter is a protein food. Those are kind of the generally heart healthful diets that we would recommend folks follow. For folks with CF, I have this caution. We talked a lot about this last year. These diets are all really high in fiber. Raw fruits and vegetables are very high in fiber. Legumes, beans, very high in fiber. And for many CF patients, that may not be the best choice for your body to manage your GI symptoms. And so I have patients who are trying to lose weight, but they have terrible constipation and can't tolerate fiber. And what fiber does for folks on these diets is keeps you full for longer. And so if you're not eating the fiber, you're going to get hungry faster. And so there's real barriers to folks following these nutrition patterns, diet patterns, to the book or whatever. I work with patients individually to figure out the balance. And usually if someone is wanting to increase their fiber, I say, let's go for it. You're also going to have to increase your bowel regimen. Or I don't know actually what I would do in this situation if things were looser. You know, maybe talking about what type of fiber, like where the fiber is coming from. Like maybe lettuces aren't the best source of fiber for you, and a different food would be tolerated differently. But usually what I recommend for people increasing is to pick one higher fiber food, have a pretty small portion of it, and see how you do, and then wait a day or two and try again. So it's like one food at a time, seeing how your body responds. And titrate, really it comes down to titrating the Miralax too, usually.
So what do you tell people who are trying to, other than weight-bearing exercise, nutritionally, what do you tell them in terms of protein requirement?
Yeah.
Like what kind of mineral do you emphasize certain trace minerals?
Yeah.
What would you say to osteoporotic old women like me?
Yeah. So honestly, if you already have osteoporosis, likely you just need calcium supplements, eating enough, right? So overall calories, focusing on protein. But like as far as calcium goes, you're probably going to need a supplement for it. Yeah, and it can get tricky. I've had some patients who maybe have barriers to getting too much calcium, and so then we need to talk about how much they're getting in their diet versus supplements. But in my experience, most of the time, patients are on an oral supplement and then just eating whatever they want.
You've talked a lot about measurements and those kinds of things, and I think I'm math challenged. I don't know about anybody else, okay? But can you just briefly talk about getting too much of something? I know too much fiber, but maybe too much protein. I know you're not supposed to eat too many oranges, but can you just talk about the extreme if we're not good at math?
Yeah. So by like constituent, so too much calories, right? If you're gaining weight, you're probably consuming more calories than you need. That's a good metric to look at. And then, like I said, like if you're trying to lose weight, cutting down like 250 to 500 calories a day may support weight loss, right? We were talking, there's other factors that go into it. So I'm not going to say will, right? And then protein. Protein's a tricky one. You definitely can get too much protein, and that can also be kind of hard on your kidneys. But using, yeah, you're right. If you're challenged mathematically, I'd say the average person, women especially, don't need more than 100 grams a day. And like we're talking about, depending on your GI system and how much you're exercising and all these other factors, maybe you need more because your body isn't absorbing it or you're using a lot. And so there are other metrics, like we're talking about muscle development. Well, if you're working out a lot and you feel like, oh, I haven't made that much progress, maybe try increasing your protein, right? And so those are like, it's a soft science, nutrition, because every person's different, and the best metric is how you feel in your body and where you're at with your goals. So I'm going to go to the conclusion slide just to wrap up. It's always a pleasure to talk with you guys. Again, like I stress on the conclusion side, so this was a good question. Working with your dietitian is really the best resource you have because it is so individualized. And even advocating for yourselves of like, these are my nutrition goals. I'm not in charge of telling anyone what their nutrition goals are. So whether you're underweight, overweight, normal weight, obese, it's up to the individual to decide what your goals are. And I think that having a understanding of maybe like, okay, if you're underweight, maybe your lung function could be worse or whatever, you have information, but there's no moral or ethical imperative to gain weight or lose weight, right? And I feel pretty strongly about that. So I hope that these conversations like empower folks to have conversations with their providers and know kind of the lay of the land so that you can have informed conversations. But yeah, it's always a pleasure. I think that's it.